Welcome to our ultrasound guided regional anesthesia workshop. Okay, it's our pleasure today to have a lot of invited speakers today. I would like to introduce Dr. Koo, the head of this department of anesthesia department, Hospital Pulau Pinang. Also, I would like to introduce Dr. Azrin and also his team. Thank you for coming today. And also to our participants, both physical and online. Okay. So before we begin our workshop today, I would like to have a little housekeeping session. Okay, so regarding Wi-Fi, you will get the Wi-Fi password at our registration counter at the front. Also, those who came physically, if you want to validate your parking ticket, you can validate it outside. There's a machine. It's a flat rate, RM7. And also to our online participants, if you want to get your MMA CPD points, we will provide the QR code on the session. Okay. Moving on, first I would like to invite Dr. Zul to read bacaan doa lah for today's ceremony.
Bismillahirrahmanirrahim. Al-Fatihah. Bismillahirrahmanirrahim. Alhamdulillahi rabbil alamin. Wassalatu wassalamu ala Sayyidina Muhammad wa ala alihi wa sahbihi ajma'in. Ya Karim, Ya Wadud, sesungguhnya kami berhimpun pada hari ini bagi menyatakan kesyukuran di atas kurniaan-Mu yang tidak ternilai. Jadikanlah kami hamba-hamba-Mu yang sentiasa bersyukur, sama ada nikmat yang sedikit, lebih-lebih lagi nikmat yang melimpah ruah kepada kami. Ya Allah, Ya Rahman, Ya Rahim, Engkau berkatilah dan rahmatilah perjalanan Majlis Ultrasound Guided Regional Anesthesia Workshop 2022 pada hari ini. Sesungguhnya Engkau Maha mengetahui bahawa kami di sini ingin menimba ilmu-Mu yang sangat luas bagi mengembangkan ilmu pengetahuan kami sebagai hamba-Mu yang Engkau redai. Justru berkati dan rahmatilah perhimpunan kami ini. Kurniakanlah kepada kami ilmu-Mu, sinarilah hati-hati kami dengan cahaya dan hidayah-Mu. Semoga dengannya kami mudah menerima dan menghayati serta mengamalkannya. Ya Zal Jalali wal Ikram, kurniakanlah jua kepada kami kesihatan anggota, kecerdasan minda, ketenangan jiwa, kekuatan semangat. Semoga dengannya kami mampu mendepani cabaran, berdaya saing dan mampu mengangkat martabat diri, keluarga, masyarakat dan negara. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azabannar. Wa sallallahu ala Sayyidina Muhammad wa ala alihi wa sahbihi wasallam walhamdulillahi rabbil alamin.
Okay, thank you, Dr. Zul. Okay. Next, I would like to invite Dr. Terrence for a welcoming speech.
Hello. Good morning, everyone. On behalf of the organizing committee and the Department of Anaesthesia, Hospital Pulau Pinang, I would like to welcome all of you to the beautiful island of Pinang and to this ultrasound guided regional anesthesia workshop. So after a hiatus of 2 years, we finally get to meet up in person to learn and to network with our fellow colleagues. The last we had our regional anesthesia workshop was back in 2020 before it got disrupted by the pandemic. So today we have over 30 participants coming from the northern region joining us here physically, and over 140 participants joining us from all over the country via the virtual platform. We are very honored to have Dr. Azrin and his team, which include Dr. Cairo, Dr. Ng, Dr. Murni and Dr. Nabila, traveling all the way here from KL to impart their knowledge and expertise in regional anesthesia. For this 2 days event, we will have lectures on various topics in regional anesthesia this morning, followed by a hands-on session on live model in the afternoon. And tomorrow we will be having a live demonstration on real patient in the OT in Hospital Pulau Pinang. So we will also be given a preview of the ultrasound guided lower limb regional anesthesia atlas, a brainchild of Dr. Azrin and his team, which will be officially launched only next year. So for those of you who are new to regional anesthesia, we hope that this will be a perfect platform for you all to kindle your interest. And for those of you who already actively practicing regional anesthesia, it will be a great opportunity for you to sharpen your skill, learning from the expert. So last but not least, I would like to express our sincere gratitude to Aspen for making this workshop possible, and the tremendous support from our advisor, Dr. Koo and Dato Yong, has ensured the successful organization of this workshop. We look forward to having a fruitful workshop, and I hope all of you will enjoy and benefit from it. Thank you.
So we will begin the day with a montage by My Sigra team on how they came with the ultrasound guided lower limb atlas. So our first guest for today needs no introduction. He is well known among the field of anesthesia, especially regarding regional anesthesia. He is a consultant anesthesiologist in the Department of Anaesthesia, Hospital Kuala Lumpur from 2005. He has various portfolios as anesthetic coordinator for robotic surgery, renal transplant, and training for masters in anesthesia. In regional anesthesia, he is the co-founder and convener of Special Interest Group in Regional Anesthesia, MySigra, and conducted international and national regional anesthesia workshops in various capacities since 2008, including OASRA in Japan. He's also a member of the National Committee in Regional Anesthesia and supervisor for subspecialty training in regional anesthesia. He is the author and co-author for various papers and guidelines in anesthesia, for robotic surgery, renal transplant, and also various documents and studies on regional anesthesia. I would like to welcome Dr. Azrin on the stage.
Okay, Assalamualaikum and good morning. Firstly, I would like to thank Dr. Koo and the Pinang Organizing Committee for allowing us some time for the soft launch of this Atlas Stroke booklet. And thank you for accommodating us in the beautiful island of Pinang. I think Pinang holds a special place in the RA fraternity in the sense that back in 2017, Pinang graciously hosted our first national level regional anesthesia symposium in collaboration with the RA Asia in Hospital Pulau Pinang. And today, I'm proud to have this launching of this first locally produced atlas in regional blocks, specifically for lower limb blocks. Thank you, Pinang, for accommodating us and allowing this opportunity. I would also like to thank members of the RA subspecialty fraternity for whether direct or indirectly contributing to the production of this project, and especially over the last 1.5 years in applying the finishing touches. Lastly, I would like to thank Aspen Medical and College of Anesthesiologists for their collaboration and support in making this project possible. And finally, I hope that the availability of this book, probably towards the end of the year, will drive up interest and many will take up regional anesthesia. And together we can elevate the practice of RA in Malaysia further. So I hope you find this book invaluable when we have made this available sometime later this year. So with that, I would like to thank again Pinang, my RA colleagues, and also Aspen Medical for this successful completion of this project. Thank you very much.
Okay, so, next, I also invite Dr. Nabila and Dr. Azmin to have the launching of the atlas. Sorry. Dr. Azrin, can you please wait? We want to give a little bit of token of appreciation. Okay. Next, I would like to also invite Dr. Nabila for our gift of appreciation. I would also like to invite Dr. Murni. Next, I'd like to invite Dr. Ng. And finally, I'd like to invite Dr. Khairul. Thank you to Dr. Azrin and Dr. Tim for coming to Pinang for our ultrasound guided regional anesthesia workshop. Okay, without further delay, we'll start the day with our first module, which is block for upper limb. So we all know, these upper limb blocks includes your brachial plexus blocks, like your interscalenes, supraclavicular, infraclavicular, and axillary blocks. It's very good especially for hand surgery. So our first speaker for today began her early career in Hospital Sultanah Nur Zahira, Terengganu, before entering her Masters of Anesthesiology and Intensive Care from UKM. She was an anesthetist in Hospital Raja Perempuan Zainab, Kelantan, before deciding to pursue further into regional anesthesia. She is currently a regional anesthesia trainee in HKL and also a member of the European Society of Regional Anesthesia. I would like to invite Dr. Murni to the stage to give the first talk for today.
Assalamualaikum and very good morning. Dr. Koo, the head of Department Hospital Pulau Pinang, the committee members of the organizing committee, and Aspen, thank you for having me, and to all the participants. So I'm pleasantly surprised to have the gift given early this morning. So let's start with the presentation, upper limb block. Okay. So click. Okay. So this is the outline of the presentation today. We will start with the applied anatomy of the brachial plexus, just a little bit of refresher, and then we'll go to individual approach, which is the interscalene, supraclavicular, infraclavicular, and axillary. And for each of these approach, I will go further into explaining the indication, equipment needed, positioning of the patient, the scan technique, the sono anatomy, and needling technique, and where to deposit the LA and the related complications. So let's start with the anatomy of the brachial plexus. So this is how it is actually applied. So when you we have 5 groups in which is involved in the interscalene approach. The 5 roots come from the ventral rami of C5 to C8 and also T1. Sometimes there are variation contribution from C4 or sometimes from T2. And these roots are found in the interscalene groove. And next, the 5 groups are going to form 3 trunks as all the roots form combine above the first rib. So blocking at the trunks is called the supraclavicular approach of brachial plexus block. The superior trunk are formed from the root of C5, C6, the middle trunk formed by C7, and the inferior trunk forms from the C8, T1. So at this level, the trunk is the most compact arrangement. So the likelihood of blocking all branches is increased. So that's the name of the spinal of the upper limb. So these 3 trunks will also split and reorganize further into 6 divisions, which is 3 anterior and 3 posterior. Blocking at this division are still called the supraclavicular approach. So afterwards, these divisions reorganize into 3 cords as it emerges below the clavicle. Blocking at the cords are called the infraclavicular approach. And the name of the cords is named in relation to the axillary artery, which is lateral to it, posterior to it, and medial to it. And later, as these branches passes caudal to the coracoid process, The branches will form the 5 terminal branches, which is the musculocutaneous, axillary, median, radial, and ulnar nerve. The musculocutaneous nerve exits a little bit earlier as compared to the other nerves distal to the coracoid process, and thus usually has to be blocked separately. So the first approach, the interscalene approach, note again that the block is at the root. So this block is actually introduced by Winnie in 1970. The block is indicated for any surgery involving the shoulder and above the mid-humeral surgery. As it most of the time it only blocks from C5 to C7, the lower cord are usually missed. So this surgery on the ulnar aspect and the arm is not advised. So next is the equipment needed. Usually just the short bevel needed is needed. A short bevel needle 50 millimeter only needed because the depth of the structures is actually quite shallow, about 2 to 3 cm. You also need a ultrasound machine with high frequency linear probe and the LA of choice, about 10 to 20 mils of ropivacaine, 0.375 for analgesia, 0.5% for anesthesia, 20 cc syringe, and also the antiseptic to clean the area, and sterile tray, probe cover, ultrasound, gel, and glove. So as for the positioning, you have to consider the ergonomics. What important is to have the operator, the probe, and the screen in one line. So in this block, operator stands at the head end of the patient, and then the ultrasound machine on the ipsilateral side, the same side, and at in front of the operator. So patient otherwise is positioned supine, slightly propped up, with head on the pillow and turned to the contralateral side. The pillow is going to be pushed to the contralateral side to create space for the needle placement and manipulation. So scan technique is either you can do of one of this approach. So one is to place the probe midline at the level of the cricoid cartilage and slide laterally to the lateral edge of the sternocleidomastoid mastod, or you can choose something which is easier, in which you trace back from the supraclavicular fossa. So the seno anatomy. So usually the classical picture that you want to see is actually a stop light sign, traffic light sign, or sometimes people describe it as a butterfly appearance, in which the body of the butterfly is the root of C5, C6, and C7. The C8 one is usually not visualized, and the either wings of the butterfly is going to be the medial scalene and also the anterior scalene. Okay, and caution when doing this block is that sometimes the phrenic nerve is resting on the anterior surface of the scalenus anterior. So take note of the position of the phrenic nerve. But sometimes even though you are careful enough, when you are successfully blocking the interscalene approach of the brachial plexus, you will most likely will get the phrenic nerve palsy and thus the diaphragm paralysis. So otherwise, the other nerve that you have to take note of is the dorsal scapular nerve and also long thoracic nerve, as it usually causes through the middle scalene. It's not visualized here, these two nerves. So take caution also of the vessel surrounding, which is the vertebral artery on the lower portion of the interscalene, and also the transverse cervical artery. Actually, the vessel is supposed to be above the anterior scalene. Sorry. So next we go to the needling technique and the position of local anesthesia. So the needle is going to be inserted in plane from lateral to medial. The needle is going to transverse through the scalenus medius to aim between the root of C5 and C6. And then when doing this block and pushing the needle with the constant pressure like you're doing the epidural, so you would be feeling the subtle pop on entering the interscalene groove. So it actually is not necessary to pierce the brachial plexus shin. It's a lot safer to not to pierce the shin to prevent injury. So otherwise, after that, when doing the block, you can try to give a bit of the LA, about 0.5 mil, giving it fast to push the needle medially and create a pocket to manipulate the needle and to place the local anesthesia in between the C5, C6 in the groove next to it. So this is the complication of doing the interscalene block. As mentioned before, with a successful interscalene approach will be most of the time successful right nerve block as well. So in patient in which you have respiratory problem, those patients which couldn't tolerate reduction in breathing capacity, so you have to be very cautious. So in this kind of patient, it is actually safer to try to limit the volume of LA. I think the volume of LA with a minimal with good spread about 10 cc is actually enough. Okay. Other complication would include the Horner syndrome, in which when you're blocking the sympathetic, accidentally blocking the sympathetic chain. Okay, if the needle is moving to medially and to posteriorly, you might have a pneumothorax. And also, as I mentioned before, there are vessels surrounding the interscalene. So the possibility of intravascular injection is there. And when there's intravascular injection, there will be the risk of having hematoma. And last but not least, the local anesthesia systemic toxicity. So next is the supraclavicular approach. Remember, when you're blocking the supraclavicular approach, you are actually blocking at the level of trunks and also divisions. So this approach was introduced by Kuhlenkampf in the year of 1900s, and it is actually indicated for the surgery of the upper arm, which is below the mid-humeral level, and surgery of the forearm, and also the surgery of the hand. When we are doing this supraclavicular block for the transposition of fistula at the brachial level, you have to supplement with this intercostal brachial nerve. Note that this area at the medial forearm is actually spared when doing the block. So this area actually supposedly to be covered by the T2 dermatum. This block can be done at the axillary subcutaneously at the as when you're doing the axillary block, or also medially on the chest. Okay, so so this is the equipment needed for the supraclavicular block. So the needles that we are using is actually a short needle, about 50 millimeter, because the depth of the structure is actually about 2 to 3 cm. Sometimes when you're having obese patient in which you have a thick supraclavicular fat pad, you might need to consider having a longer needle, 80 millimeter. So you also need ultrasound machine with high frequency linear probe, about 20 mils of LA. It's either 0.375 of ROPI for analgesia or 0.5% for anesthesia. However, you might still use a little bit less if you manage to put the local anesthesia adequately around the brachial plexus. Okay, 20 cc syringe, accused chlorhexidine for cleaning purpose, and also the sterile tray, probe cover, ultrasound gel, and also glove. So next, the positioning for the supraclavicular block. Considering the ergonomics again, it is best if the operator stand at the head of the patient, or also sometimes at the side of the patient is also okay. So if the operator is standing at the head of the patient, it is best if the machine or the screen is put at the ipsilateral side of block in front of the operator. If the operator is standing at the side of the patient, then the screen would be on the contralateral side of the block. Remember, the most important thing is to keep everything in line, which is the operator, the probe, and the screen. Okay. The patient is positioned supine, slightly propped up about 30 degree. Head is put on the pillow and turned on the contralateral side. And the pillow is pushed to the contralateral side to create space for needle placement and manipulation. So scan technique, easy. You just put the probe at the supraclavicular fossa at the mid-clavicular area, and then you just need a little bit of manipulation in which tilting the probe caudally toward the first rib and the thoracic inlet to improve the view. Next, the sonoanatomy of the supraclavicular approach. So the depth is actually quite shallow, about 2 to 3 cm, and the most important structures to be identified is actually the subclavian artery, okay, and the first rib, and also the supraclavicular approach. Usually the brachial plexus is viewed as a bunch of ribs lateral to the subclavian artery. So if you're having difficulty to find the structures, you can still trace up and down from interscalene going down to confirm the position. And also it is actually safer to put Doppler so that you can take note of the surrounding vessels. Sometimes there's a suprascapular artery going above, or sometimes going through the in between the trunks of the brachial plexus. Okay, and also below the rib, take note of the pleura sliding beneath it. So next, the needling approach and the deposition of local anesthesia. The needle is inserted in plane from lateral to medial. The first target would be the pocket, inferior pocket between the first and the subclavian artery. Then the effect that you wanted to see is the lifting of the artery from the first rib. On the first pocket here, you can deposit about 8 to 10 ml of LA. You can even give less if the spread is good over here. So the next target would be either above of the superior trunk or between the superior trunk and the middle trunk. The total volume of LA to be deposited here is about 8 to 10 ml of LA. So be careful when advancing the needle. Try not to cause paresthesia, because that would mean that the needle would be in contact or very near to the nerve. So when you're about to enter the space, you can push a bit of local anesthesia, about 0.5 ml, but you have to inject it fast to create a safe pathway between the needle tip and the nerve. And then you can push a little bit further of volume while advancing the needle. So the complications related would be still pneumothorax, which is quite common because there's a pleura just beneath it. So be careful with the needle insertion. So to avoid this pneumothorax, it's actually advised to rest the tip of the needle on the first rib and do not go beyond the expected depth of the needle, which means that if you're using a longer needle and the structure is actually not as deep, try not to go deeper than the expected structures of the brachial plexus. So the next complication will be phrenic nerve palsy, although it's not as common as the interscalene approach because of the proximity of the brachial plexus to the phrenic nerve. The risk of having phrenic nerve palsy and thus diaphragm paralysis is still there. That also include the risk of having Horner syndrome due to blockade of the sympathetic chain, and the risk of vascular puncture is still there because you're moving close to the subclavian artery, and there's also suprascapular artery traversing the brachial plexus as well. So the intravascular injection can cause LAS, local anesthesia systemic toxicity, and the risk of patchy or failed block is still there if the LA is not deposited correctly. So next would be the infraclavicular approach. Again, I would like to remind the participants that actually the infraclavicular approach is done at the level of cords. So this approach is actually among the earlier pioneers of doing the infraclavicular approach would be Bazzi in the 1917, but the approach is much more medial. And then this approach is actually revised and also had undergone some modification, in which on the latter part there's more lateral approach. So probably the one approach that we are using now, the lateral parasagittal approach, is actually introduced by Wilson in the 1998. So the purpose of going lateral is because of the increased safety of doing the block. There's less risk of having pneumothorax because the structures are more lateral. You're avoiding the pleura. So this block is actually indicated for surgery involving mid-humeral down, elbow, forearm, and also surgery of the hand. So these are the equipment needed for the block. As opposed to the last two previous block, you would probably have to consider using a longer needle, about 80 to 100 millimeter in length, because the structures is actually positioned slightly deeper. On average adult, the depth would be still around 4 to 7 cm, and then you have to angulate the needle. Okay, the ultrasound machine, you need it with the high frequency linear probe. If the depth is more than 5 centimeter, you probably have to consider using a curvy linear probe. If it is more feasible, there's no harm of using other approach. Okay, try to make it easy. So the volume of LA is about 20 to 30 ml, ropivacaine 0.375 for analgesia, 0.5% or even higher for anesthesia. Just take note of the maximum dose. Try not to exceed that. So you also need 20cc syringe and also cleaning solution, the sterile tray, probe cover, ultrasound gel, also glove. So positioning, again, considering the ergonomics, because it makes the blocking actually a lot easier. The operator is positioned at the head end of the patient, ultrasound machine, ipsilateral to the side of block and in front of the operator. Patient otherwise is positioned supine with the ipsilateral hand abducted to 90 degree. So the purpose of abducting the hand is to improve the space beneath the clavicle. You're improving your access and also improving your vision. You're actually also bringing the structures a little bit more superficial as opposed to bringing the head down. But However, if the patient had some limitation, maybe pain or also having CAS, any position will actually do, provided you can view the structures. Okay, the head can be turned contralateral a bit, but actually neutral position is still okay for infraclavicular approach. So scan technique, there are many approaches of doing the infraclavicular block, infraclavicular approach. But today I'm just gonna talk about the lateral parasagittal approach because this is one of the safer option. So in this approach, the probe is placed below the clavicle in parasagittal plane medial to the coracoid process. So this coracoid process you can palpate on the anterior surface of the shoulder and to try to move the upper limb. There's supposed to be a prominence which can be felt when you're moving it. So just put medial to the coracoid process below the clavicle. So the sonoanatomy of the infraclavicular approach, the depth again, I would like to remind you, still in average about 3 to 7 cm. So remember to set your screen appropriately. So the important structures to be identified is actually the axillary artery. Distal to the axillary artery or caudal to it, you might actually have to see whether there's any axillary vein, but it is okay if it's not visible. Sometimes it is compressed by the probe. Cord is actually arranged in relation to axillary artery. The lateral cord at 10, posterior cord at 6, and also the medial cord at 3 o'clock. Above these structures would be pectoralis muscle, and below it would be subscapularis muscle. If you can see the pleura sliding beneath it, you are probably more medial than you intended to be. So be careful when you're looking at pleura sliding beneath it when scanning. And take caution is actually apart from having this axillary artery and vein, there's extra vessel that have to pay attention to, which is the thoracoacromial artery, which coming from the axillary artery. Next is the needling technique and the deposition of LA. So the needle is gonna, the probe and needling is gonna be in plane. The angle is actually has to be quite acute because of the depth of the structures, and you might need to, or you might have to consider to heel in the probe to improve the angulation or also facilitate access of the needle. So the needle's gonna come above cranially. Try to go below the lateral cord and pushing about 0.5 mil LA to push away the needle. And then when you have a safe pocket, advance gradually and also can to create a U-shaped spread of local anesthetic. When you're going through the, when you're going below the lateral cord and deposit the pocket of LA, the aim is later, if possible, to go below the artery to ensure a proper spread of the local anesthesia. So the total volume here, again, remember about 20 to 30 mils. So the complication will include the nerve injury, okay, IV injection, local anesthesia toxicity, hematoma. When you're medial, you can cause pneumothorax as well. Rarely there's still right enough palsy during doing this infraclavicular approach. It occurs when using volume which is large, about maybe 30 mils and above. So the next approach is, and the last one, it will be the axillary approach, in which the block is done at the terminal branches. case. This axillary approach is actually introduced by William Halsted in the year 1884. It's indicated for surgery of the elbow, forearm, and also the hand. So these are the equipment needed. For this block, you would need a short bevel regional block needle. Usually, most of the time, the needle length will be just 50 millimeter because the structure will be actually quite superficial, about 2 to 3 cm. You will also need ultrasound machine with high frequency linear probe, LA volume about 20 mils, ropivacaine 0.375 for anesthesia or 0.5% for analgesia, 20 cc syringe, 0.5% of aqueous chlorhexidine for cleaning purposes, the sterile tray, probe cover, ultrasound gel, and also glove. Okay, a momentary pause there. Sorry for the technical glitch. So next is the positioning for the axillary approach. So again, considering the ergonomics, one of the important part of the block is to make sure everything in alignment. Again, the patient, operator, and the ultrasound machine. For this approach, this operator can stand at the above of the patient's head or at the side of patient, but make sure everything is in line. So for this approach, patient lies supine, arms abducted, forearm supinated, and elbow flexed, hand behind or above the head. So the scan technique, the ultrasound probe is placed at the axillary fold, lateral to the pectoralis major. Remember not to put the probe too distally or you will miss the important structures. And you can also palpate the axillary artery and put the probe at the middle of the artery. Okay, these are the sono-anatomy of doing the axillary block. The depth is actually again is quite superficial, about 2 to 3 cm. It is important to identify this axillary artery in which the nerve is arranged around it. The axillary vein, there might be several veins around it. On the posterior part of the posterior to the artery, and also to when you're in the correct position, you're supposed to able to view the conjoint tendon as well. So initially when doing this block, this individual nerve might not be that visible. It might be the vision might be better after giving a little bit of LA. You can see the nerve floating around the locus. This muscular cutaneous nerve has to be blocked separately again, remember, because this muscular cutaneous nerve branches off after the coracoid process. It usually lies between the biceps and coracobrachialis. To confirm this position of the muscular cutaneous nerve, you can slide the probe up and down. When you're going proximally, usually this muscular cutaneous nerve will fuse with the rest of the nerve in the brachial plexus. It will, when you go up, the muscular cutaneous nerve will move into this to join all these other nerves. So this is the anatomical variation of the arrangement of the terminal branches of this axillary approach. Usually, again, muscular cutaneous nerve is actually outside of the sheath most of the time. The first arrangement is the commonest arrangement, is about 65%. The ulnar nerve is actually positioned at from 1 to 3 o'clock. Median nerve from 10 to 12 o'clock, and radial nerve from 6 to 4 o'clock. Usually the radial nerve rests on the top of the conjoint tendon. It's actually among the biggest nerve in the axillary approach. So the rest of the arrangement is actually the variation, but it's not really common. So next is the needling technique and the position of local anesthesia. Again, the best approach when you're starting is the in-plane approach. The needle is pushed by constant pressure. When you're reaching near to the nerve, you can push about 0.5 ml of LA fast to hydrodissect to create a safe pathway to advance the needle. This small volume of LA also helps to identify the nerve and also push it away from the vessel, and thus lessen the danger of nerve contact and also causing nerve injury. So there are 3 points that you have to consider when doing the block. So the first one is below the artery or above the conjoint tendon, aiming for the radial nerve, the volume about 8 ml. And also the next approach, the second point would be above the artery, aiming for the median nerve. Okay, when doing this approach, because you're very near to the vessel, it is important to hydrodissect to clear the pathway. And also you can advance while giving the small liquid of LA, then push further to aim for the ulnar nerve, the volume about 8 ml. And then the nerve that has to be blocked separately is the musculocutaneous nerve within the coracobrachialis muscle, about 4 ml of local anesthesia. Okay, this is the picture trying to demonstrate how to do the block of the radial nerve. The needle is coming in plane. The needle is well visualized. In this approach, the needle is actually aiming above the conjoint tendon, below the radial nerve. When the upper manage to insert within the containing fibrous sheet, the LA, when giving, is going to delineate the outer border of the nerve better. And then you can also aim between the axillary artery and radial nerve, but careful to create a safe pocket before advancing the needle to prevent puncture of the vessel or the puncture of the nerve. Okay, next is the block of the median nerve. So in this approach, you can either go between the medial nerve and axillary artery or above it, whichever is easier for you. Okay, and after giving the medial nerve, creating the safe pocket of LA, you can advance the needle further to block the ulnar nerve. Okay, and then the last nerve which has to be blocked separately is the musculocutaneous nerve. Again, when doing this block, if you can't visualize the musculocutaneous nerve, you can slide the probe up and down. You can recognize this musculocutaneous nerve lying in between the biceps brachii and coracobrachialis, or sometimes it can be seen within the coracobrachialis. Okay, the volume of LA needed for musculocutaneous nerve is actually quite low, about 3 to 4 mils only. So a little bit extra when doing the axillary brachial plexus block is the block of the intercostal brachial nerve. Remember, there's a strip of skin on the inner upper arm, which is spared when doing the brachial plexus block. This block is actually good if you are doing the transposition of BBF. So it's also good if there is actually a tourniquet on the upper arm. So actually you just slide the probe a little bit more medial, and then there's a superficial fascia in the subcutaneous tissue in which you can deposit the LA there. The other approach of the intercostal brachial nerve is at the on the chest, in the same plane of the pex block. It's actually just one level higher, about on the second to the third of rib, below the pectoralis muscle level. So the complications of the axillary approach would be vascular puncture, because there's a lot of vessel arrangement around it. When you're puncturing, probably you can get hematoma as well. And possibly if a large volume of LA manage to get into the system, there will be LA toxicity. If you are in contact of the nerve, you'll probably get nerve injury. And also there is a risk of block failure as well. So in conclusion, when you're doing the surgery, when you're doing the anesthesia of the upper limb, try to get the block which is most distal but would suffice for the surgery. And if there is any difficulty, you can always switch to do other approach whichever is feasible. Okay. These are my references for the presentation. Okay, thank you so much.
Okay, thank you, Dr. Murni, for the presentation. Actually, now we open the floor for any questions. Those who are participating online, you can also ask questions in the chat box. We have a question from our online participant. Okay, is interscalene block still the choice of block for shoulder surgery, while we have an option of superior trunk block?
Actually, for shoulder surgery, there are many options now apart from the superior trunk block. You can also do the axillary and also suprascapular nerve block as well, which is the shoulder block. It is called the shoulder block. Okay, there are several options now. I think there are papers of suggesting using in the infraclavicular approach of costoclavicular block as well for analgesia of the shoulder surgery, which is quite distal, but it is not supposed to be a standalone analgesia. I think it has to be combined with the superior trunk block. Okay.
I myself have a question. Okay. Actually, in between infraclavicular and supraclavicular block, I saw the dermatome is almost similar. So why would you choose one over the other? Is there any like certain factors?
Actually, the supraclavicular block, because of the arrangement of the nerve, actually quite compact. The onset is actually faster, and you tend to able to be block most of the branches efficiently. So when you're doing the infraclavicular approach, it actually depends on where are you blocking. You might miss several branches if you are quite lateral. That's it. And then the infraclavicular approach, you have to be wary of the risk of having a pneumothorax when you're going medial. Okay. For starters, I would advise to do the lateral parasagittal approach because you're avoiding the pleura. Okay. And there is suggestion of doing the costoclavicular approach for obese patient, but because of the depth of the structures is actually quite shallow even in obese patient. There's a suggestion to do costoclavicular approach of infraclavicular approach. Because this arrangement at the costoclavicular approach of infraclavicular block is actually done medially, more medially. The good thing about that is that the structures is actually arranged just lateral to the axillary artery in one position. So you don't have to move about your needle so much. You just target in between the lateral and posterior cord. Sometimes you can just give one injection, and there is suggestion to do 2 side of injection, just as compared to the other infraclavicular approach is actually much shallower. So for obese patient in which you have a thick supraclavicular pad, maybe you can consider doing the costoclavicular approach. But again, the other thing about doing the approach is that you have to put it below the clavicle and tilt the probe. So the tilting might cause problem in which you probably have problem to visualize the needle properly because of the tilting. Okay, is maybe not so easy for those who just started. Okay.
Thank you, Dr. Murni. Any other questions from the floor? Okay, so if there's no more questions, actually we have a short break, a coffee break until 10 o'clock in the morning. So, so there's a breakfast provided outside. Participants physically can go at 10, and we'll start back at 10 o'clock in the morning. Okay, thank you.
Thank you so much.